Okay, good morning everyone and welcome to today's Teach Educational Round session. Before I continue, I just want to make sure that you can all hear and see me clearly. Wonderful, thank you. So welcome to today's session. So the topic will be intervening early, delivering evidence-based care for risky alcohol use among smokers in primary care. Today's presenter is Dr. Peter Selby. If you are interested in obtaining a letter of completion for today's session, you must have registered for the webinar and completed the pre-learning assessment. You must have signed into the live webinar using your first and last name for attendance purposes, and you must complete the evaluation and post-learning assessment following the webinar, which will be emailed out to you later today. These webinars are being live tweeted. Follow the CAMH Nicotine Dependence Services on Twitter at @PSQuitSmoking. To follow the tweeting or to post your comments, use hashtag #TeachWebinar. Okay, today's faculty presenter, Dr. Peter Selby, is the Director of Medical Education and Clinical Scientist at the Center for Addiction and Mental Health. He's a professor in the Departments of Family and Community Medicine, Psychiatry, and the Dalla Lana School of Public Health at U of T. He's also a clinical scientist in the Department of Family and Community Medicine. And I'll let you all read the rest of the bio. These are our disclosures, Dr. Selby's disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Contents of the slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussion, set out only general principles and approaches to assessment and treatment and do not replace the need for individualized clinical assessment and treatment plans. Okay, now before I hand it over to Dr. Selby, I'm going to do a couple of polling questions just to get a sense of the group today. So the first question will be, what region are you from? Okay, it looks like it's a pretty even split between Southwest region and GTA. The next question is asking what discipline you belong to. Okay, and the majority of you at 31% are registered nurses. And the last question is, what type of organization do you work for? Okay, and the majority of you are from family health teams. Thank you for participating, and now I will hand it over to Dr. Selby.
Thank you very much, Tanya, and welcome and good morning. In addition, I think we also want to acknowledge the Canadian Cancer Society Research Initiative that is funding us on this project that we're doing with respect to alcohol and tobacco and its role in the prevention of cancers. And some of you who may have been at my previous talk and webinar would have heard about the combined effects of alcohol and tobacco. So we'll do a quick review of those health implications, but the focus today is going to be talking about how do we get evidence-based alcohol screening tools into primary care, because as we know, most people with substance use disorders and alcohol problems actually never make it into the formalized addiction treatment centers. They actually get seen in family medicine and in primary care settings. But it is important to understand the continuum of alcohol use and understand who needs to be connected to the addiction treatment system, who can be managed within the primary care system, and how do you create this collaborative links. And in today's call, I understand we have people not only from our primary care sector, but we also have our colleagues who work in the addiction treatment center. So hopefully, we are beginning to start to create some sort of understanding that the use of alcohol exists along a continuum, and people with alcohol problems are seen in multiple settings, including primary care, including the addiction treatment center. And so as regionalization improves, I hope that primary care settings will have better collaborations with addiction treatment centers and vice versa, and including public health settings as well, because most people with these conditions land up touching us in different ways. The other issue for our particular interest within STOP is that we've been noticing some data and about who's quitting and who isn't quitting, and clearly we talked about alcohol being one of the big determinants why people aren't successful. And so today, the other thing that we will talk about is how do we integrate alcohol screening tools into routine primary care practices to STOP, and also how can you tailor brief alcohol interventions to address patients' at-risk drinking patterns, much like how you deal with the tobacco use issue. Similarly, similar skills of motivation interviewing being used to help people also address their use of alcohol. So alcohol is the second most harmful substance in Canada after tobacco, and one of the so you have to understand use and abuse go along a spectrum. So some people may use alcohol but may not be addicted to it, or may not have what we would call problem drinking. They use alcohol, get intoxicated, fall down, injure themselves, and they have a bad outcome. Or they'll drink and drive, and some of you are seeing this play out in the news with respect to some significant consequences of harm to others from somebody's alcohol consumption and drinking and driving. So the person may or may not have a problem with alcohol, but they drink and in circumstances where they shouldn't, and can cause harm to themselves and others. On the other hand, it may, with people who are vulnerable, may cause things like delirium, disinhibition, psychosis, problems with their vision, and obviously we talked about risky behaviors, especially in young people, for example, in universities, etc. Alcohol binging is associated with not only injuries and falls, but unwanted sex and pregnancies and STIs and other problems as well. And the person isn't addicted, but just that intoxication is leading to these problems. So that's just that early part of use in a problematic way. Even in the acute setting, can cause problems. Long-term use can affect decision-making, memory, anxiety, cause brain damage. It's associated with strokes. Number one cause of hemorrhagic strokes is alcohol is a big risk factor, and clearly a lot of people think that they're drinking alcohol to help their heart, but actually in the long run it is associated with arrhythmias like atrial fibrillation, etc., and also hypertension. A common cause of high blood pressure is people's excess use of alcohol. Moving on, clearly things like pancreatitis, stomach ulcers, fatty liver disease, hepatitis, cirrhosis clearly affect fertility, and missing from this is the whole issue of cancers, which is just down at the bottom, but the cancers are really up in this area of the head and neck mostly, and the gut and liver. So we have to pay attention to that. And then clearly, of course, it affects nerves and nervous system, so chronic use can affect things called like neuropathies, etc., and also cause problems like problems with the muscles as well, and the muscles can waste away. So alcohol in the long, in sort of harm that it causes is both short-term and long-term, and occurs at any age. Now we use categories to look at alcohol use. Now most Canadians, although they have tried alcohol, do not use it in an excessive way, and so most Canadians will fall into a low-risk use where they either don't drink at all, or they drink in ways or amounts that are not harmful or risky. But then the population that is overrepresented in primary care, and especially among smokers trying to quit, are this population, mostly in section 2, the harmful or risky use, and then a small group are in the dependent use, which we would call addiction or alcoholic or alcohol dependent or alcohol use disorder. And so this group often comes to our attention because they are, they're obviously the family members are coming in, other people are coming in, they are coming in, and they are also seen as being a big problem. And so we think alcohol is a big problem. They don't seem, it's like a chronic condition. They don't seem to be responding to treatment, and we often watch them whittle away and lose everything under our very eyes. So let's look at the level 2 first, because that is the most common. What is harmful or risky use? It's been defined in several ways, but one way to think about it is when alcohol use exceeds the low-risk limits. And that low-risk limits is a bit fuzzy as to what that means, and we'll talk about how to set that limit and think about it. And they may not be having significant consequences of the use. They're generally functional. They're working. They're fulfilling most of their role responsibilities. They're not otherwise unhealthy, but they may be drinking at a level that is putting them at risk. And they may be missing, for example, having the hangover and missing that meeting, or be a little irritable and losing and having family distress because they're drinking. They may be having that, but it's not the major point. I think as you're getting further up in that's where you're getting the failure to fulfill responsibilities, getting further into that dependence or the addiction or the use disorder problem. So I like to show this picture of the iceberg because in our settings, especially in primary care settings or in the emergency room settings, we will see the alcoholic. And for every one alcoholic who's alcohol dependent or alcohol use disorder, where their life is driven by alcohol, they're waking up in the morning having a drink the first thing, they spend drinking, they aren't able to function as a family member, as a worker, they're not productive, and all they do is drink, in and out of the hospital, etc., getting detox, getting back in. That's the tip of the iceberg. That's about 6 to 7, and it stayed static in society. It hasn't gone up. That number has stayed pretty much standard, which is approximately 6 to 8% of the population. But what is often hidden from our eyes are these people below, the so-called at-risk or problem drinkers. We don't often see them in that way because they come in, they'll come in the emergency room because they fell off a ladder, or they fell down some steps, or they had a bit of an accident. Or they have, in family medicine, they'll come in with hypertension that's not coming under control, or they'll come in with insomnia, or they'll come in with, feelings of depression or psychiatric things, or they may have some problems in their marriage or their relationships. And we don't often, because we're not screening for their use of alcohol, we miss the role of alcohol in causing these problems. So for every one person with alcohol dependence in your practice, roughly there'll be 4 others who are in that problem drinking category or at-risk drinking category who are essentially flying under the radar at one level because we're not getting to the core issue of their alcohol use. And then the dependent use is, or the addicted person, or now what we would call a severe alcohol use disorder in DSM-5. This person is that classic use continues despite persistent problems. Patient's life relies on use, distress or disability, and there's tolerance and withdrawal. So these are the people who get the shakes. These are the people who are, in detox. These are the people who are falling over, etc. So, during this, we're going to talk about 2 case studies, and the 2 case studies that I'd like to talk about. I'll just introduce both of them right now. We'll have one, a man and the other woman, and these are not uncommon to some of the profiles that we've seen in the STOP program in primary care. So, roughly an older man married, living with teenagers and his partner. He's employed in a stressful job, smoking daily, is in the program, but may have disclosed to you that at a local bar most nights to de-stress with drinks. And And when we look at the outcome, you're giving them nicotine replacement, we do the follow-up, and we notice that the person either hasn't completed their program, or they've dropped out, or they've come in and out, they've been, sputtering along, they come in, they try for a bit, they go back out, and then in follow-up, they are either not contactable at the 3-6 month point, or they have relapsed. Maria is, on the other hand, a woman who's younger and recently graduated and is again trying to quit smoking, but is saying that she's having 1 to 2 glasses of wine with roommates in the evening, and seems pretty innocuous, and we're much more likely to just sort of say nothing about it and move on because we're focusing on the smoking. So we'll bring these up as we go along today and how to look at that. So first of all, let's take a look at roughly what is the effect of heavy alcohol use on smoking cessation rates. And this is a study out of my colleague in San Francisco, Gary Humphreys. Look at the date in which this was done, 1999. So these are old studies. These are not necessarily new studies. So we've known this for a while. And if you take a look at this in drinkers versus non-drinkers, looking at their ability to quit smoking for 7 days and continuous absence rate, you can take a look at this. At these weeks, the people who continue to drink have a much lower rate of quitting. Roughly about a 20% difference at week 12, which is when most of the programs, and our program is 26 weeks, so you could expect, compared to your non-drinkers, your drinkers are approximately half as likely to have quit. And then if you carry this out, you can see that they also are not able, even if they do quit, are not able to maintain the abstinence, such that by the end of the continuous absence rates at the end of a year, we'll see a big difference. Half as many will be continuously absent. So if we're making an effort to help people quit, how can we make that quit more successful, especially given that we're helping them with a whole bunch of things to try to quit, such as NRT and counseling. Now, the other issue that often people don't recognize is that there's this multiplicative effect of cancer risk from dual alcohol and tobacco use. Now, clearly, if you look at this risk, it's 1.36. So clearly, any alcohol, any tobacco increases your risk of cancer. And if people are only using alcohol, it's 1.36. If it's only tobacco, it's 1.21 for aerodigestive cancers, and these are squamous cell cancer of the esophagus. But when you look at the combined effects of alcohol and tobacco, it goes more than just adding these two up. It's 3.28. So there's something about how alcohol and tobacco work together. They both have carcinogens, and they act in synergy to cause a worsening cancer. And it also could be that when people smoke and drink, they consume more of each. So in Canada, there have been many, and around the world, there have been many low-risk drinking guidelines. So one way for us to first think about these are lower-risk guidelines. There's no zero risk. But we're balancing that with some of the enjoyment that people get from drinking alcohol in a non-destructive way. But people do need to understand that. So Canada's low-risk drinking guidelines, which were developed through the Canadian Centre of Substance Abuse with a multitude of partners, including the alcohol industry, has come out with these guidelines, which say that for women, no more than 2 standard drinks, and we need to think about standard drinks. These are not the 8-ounce glasses of wine or 9-ounce glasses of wine that you get when you go out. It's the 5-ounce glasses of wine. And according to that guideline, it's 2 drinks on most days and no more than 10 drinks per week. And this guideline is for obviously women who are not pregnant or do not have, and again for men and women, for people who don't have reasons why they should be abstinent, such as having had an alcohol problem in the past. And for men, it's 3. So 3 on most days, 15 drinks a week. And again, often if it's no more than 3 drinks on most days, and 15 drinks a week, which means there are days of abstinence, because it's not drinking. If you drink 3 drinks every day, that's 21 drinks. So clearly there are days where there should be some abstinence from alcohol as well as reduced drinking. On the other hand, when we take a look at cancer, so these are, will reduce most of the risk from sort of falls, injuries, accidents, and addiction. But from a cancer risk perspective, the evidence suggests that the real amount should be for women to reduce their cancer risk, especially breast cancer risk and other women cancers, is only drinking less than 1 drink a day. So it's less than, and you can see how this says no more on the left-hand side. This is less than, and again for men it's less than 2 drinks per day. And they, so in thinking about this, we have to think about at what level of risk are people willing to tolerate. The lowest risk is with this. Now, some people will say, well, there's a health benefit to drinking alcohol from a heart, it's cardioprotective. And actually, that is generally not accepted anymore as being that valid, because for the bulk of the population, it isn't protective. In fact, the risks go up with any amount of drinking for men, especially young men and women. And in fact, the cardioprotective effects only accrue to those who are completely sedentary, smoking, sit and do nothing else, and are obese and have high cholesterol. And in those situations, you get a benefit from a drink every other day. And so this, the health benefits at a much lower level and for only a very subset of the population. So although everybody likes to believe that socially, that drinking is good for their heart, in fact, it is probably bad for your heart because it causes a lot of arrhythmias, and atrial fibrillation is a big problem in our practices as well. So how much is 1 drink? When we do the Teach in-person, the Health Promotion 6-pack, we have a little bit of an exercise where people pour their own standard drinks as to what they think, and people just sort of eyeball it and sort of pour it out, and when you actually measure it, nobody gets it right. So when we take a look at this is actually a pint, and this is more than a standard drink, because a standard drink in Canada has 5% alcohol and is 341 mils. So if a patient says they're having beer, first of all, a lot of them don't think beer and wine are alcohol, and they say, well, I don't drink alcohol, but I just drink wine and beer. So you have to clarify with them. But that beer actually, depending on the kind of beer, when they say they drink beer, you'll get a better estimate if people drink bottles of beer rather than if they're getting pints, etc., or half pints. So roughly, a standard drink, every standard drink has 13.6 grams of alcohol, and this certainly, this picture here of a pint has more. So the real standard drink would be 1 bottle. Ciders and coolers, similarly, a 341 ml of a cider or cooler with 5% alcohol content. Wine, 5 ounces of 12% alcohol. So 5 ounces, and therefore, if you look at a standard bottle of wine, it's about 5.5 standard drinks per bottle that people are having. So if people are drinking a bottle of wine every evening with their meals, they're probably exceeding guidelines, whether they're a man or woman. And then with the distilled spirits, it's again 1.5 ounces of 40% alcohol content, and that makes a standard drink. And the idea is that it doesn't matter on the type of alcohol consumed. What seems to be is there's alcohol in it, that is the cause of the harm. So it's just a matter of volume and concentration of alcohol. So this only has 5% alcohol, this has, wine has 12%, and distilled alcohol has 40%. So, and sometimes you'll read of it as 80 proof. So understanding that these are all the same, and in essence, that's how we're trying to get people to understand their drinking in terms of standard drinks, rather than whether wine is better than beer versus scotch or gin or vodka. That's not the issue. So now, what's the rationale for intervention among STOP participants? Because now, notwithstanding our colleagues who are coming here from the addiction agencies, where alcohol is often the most common reason, we've noticed that even in primary care, if you take a look at this. So if we take a look at Ontario smokers who drink above the guidelines is over 500,000 Ontario smokers are drinking above the guidelines. Within STOP, and this is approximately about 46,000 people, more than 8,300 in the last year were noticed to be drinking above the guidelines. So we've got a large population of people spread across within our setting who are drinking and at risk. And so if you look at the stop participants compared to the other people and smokers and non-smokers in the general population, so that's the blue and the red, stop participants overall are much more likely to be exceeding the guidelines. So 37% versus 27% versus 16%. In men, 45%, 25%, and 12%, and women, approximately the same with respect to smokers. So our male smokers who are coming in are also much more likely to be drinking above guidelines. And again, might be affecting their, and we know it's affecting their quit outcome. So what does screening, brief intervention, and referral, or SBIRT, mean? And now this is I work in both areas of addiction, both alcohol and tobacco, and what has been fascinating to me is that the alcohol field developed their 5As, and the tobacco field developed its 5As, but nobody ever thought of bringing it together because, for all sorts of political reasons, they kept it separately. But all of us know that our people who are smoking are much more likely to be drinking. And it's kind of weird that we do the same for tobacco and the same for alcohol, but we never put those two together. The interventions, the elements of the intervention are pretty similar. The medications may be different, but the interventions are very similar. So SBIRT has been studied since the 70s. It's been well validated in randomized controlled trials. And here are the elements: screening people for their alcohol use, providing a brief intervention, and where appropriate, referring them to a treatment program for that. And taking a public health approach to this makes it very effective, because what happens is, as we said, most people with these alcohol problems are not seen in specialized systems. In fact, most of the problems in society from alcohol are not because people are alcoholic. Most of the harms in society today from alcohol are because people drink too much or in situations where they shouldn't drink and cause harm to themselves and others. And overall, because there are more people doing that than there are alcoholic, the burden from alcohol actually comes from people who drink in slight excess and not the alcoholics. It's not to say that we ignore people who are alcoholics, but if we're going to have an impact and reduce the public health impact and the health impacts of alcohol, we actually have to work on this middle group who have mild to moderate or have at-risk drinking or problem drinking. So here's the downside. As people have been trying to push this into primary care, just like we try to do smoking in primary care, there were so many preventive services needed, but so little time in primary care, that to fully satisfy all the recommendations of the task force, U.S. task force, you would need 7.5 hours per working day to just provide prevention. So in many ways, it actually makes sense that every primary care setting should probably have a prevention practitioner who is essentially working on prevention only. But we're slowly getting there, but we're not there yet. Now, alcohol SBIRTs show great potential for impact. When you look at, of all the 25 recommended preventative services ranked on clinical preventable burden and cost effectiveness, paradoxically, it's one of the lowest preventable services that are implemented, even though it ranks very highly. So clearly, childhood immunization series, very important. And then comes tobacco use screening and brief intervention, which is what you're doing through STOP and I've learned through TEACH. So you're doing it. And here, just look at, close second is alcohol screening and brief intervention, followed by colorectal cancer screening and influenza immunization. So if you have these, how come where the burden of illness from alcohol is greater than the flu and colorectal cancer screening, how come we're not doing this? So it's an interesting paradox, and part of it is because we haven't actually had the training and the pathways to make it happen effectively. So, lots of researchers have looked at it and have said what makes screening brief intervention ideal in primary care settings is because generally primary care settings are moving much more from a reactive kind of setting where we are looking at much more preventative services and proactive delivery of services, chronic disease management. And so routine and universal screening at all primary care appointments is becoming a way for us to now create population-based approaches to the patients we are responsible for in our rosters. And the other thing is that in many primary care settings, we are beginning to develop treatment extenders. Either we're getting consultants coming into the practice, or we have other healthcare professionals like maybe a mental health and addiction counselor, or other health professionals like a social worker or occupational therapist, health promoter, who can now create some of those connections between primary care and the addiction treatment centers or the more specialized centers if those are required. The other thing that has happened is patient-centered communication strategies are often the hallmark, and we've got the primary care medical home where all care is supposed to emanate from, whether it's delivered there or coordinated from there. That is important. And the other thing is that this screening and brief interventions is because they are brief, does not mean that they have to take hours of the clinician's time to have an intervention. Right now, because it's not done systematically, it does end up taking lots of hours because all you're doing is dealing with putting out the fires of patients who are drinking to excess, and we don't have a way of managing that. You can imagine the number of patients who I've seen who have 2 or 3 antihypertensive medications. And when we see them for their drinking and simply get them on a regime of either abstinence or reduced drinking, their blood pressures come under control. They need much less antihypertensive or even discontinuation of a couple of them. And we've also seen in patients with diabetes. They're drinking, people don't recognize the amount of calories they're getting through the alcohol. And with that, the alcohol calories that you're getting, and a lot of times sugar, especially if they're drinking wine, their blood sugars are never going to come under control. So these brief interventions can help a lot of these other conditions that people are showing up with as well. And clearly there are validated standardized screening tools which, as most primary care settings which have rostered practices have EMRs, these validated standardized screening tools are becoming an important way to make sure we are reaching and servicing our population, not just reacting to their coughs and colds and acute problems that they show up with. So the evidence is pretty strong, and some of it, as you can see, there's been meta-analysis and trials done, for many, many, many years, more than, going back into the last century as well. And essentially in controlled settings, with at-risk of problem drinkers, you can see a 13 to 34% reduction in alcohol consumption at 12 months. So just that brief counseling, no medications, just simply telling people to reduce their consumption of alcohol can lead to 13 to 34%. And this is not very different than what we're getting in STOP with smokers. So, so it's an interesting thing to think about. Behavioral interventions seem to have one in 3 people who we intervene with will have a benefit from it. So, so it's not a bad thing to do, and that's one of the reasons why it's seen as being cost effective, because most people trust their healthcare providers to provide them factual information, and if done in such a way, you're going to have that outcome. In Canada, the guidelines have been developed by CCSA and the College of Family Physicians of Canada. This is just a screenshot of the handout, and it incorporates the Canadian low-risk alcohol drinking guidelines. And unfortunately, they do not include the cancer guidelines, but this guideline is available for download at this website at www.sbir-dba.ca, and it's bilingual. So what are we doing with all this information and our patients and your patients and in the STOP program? So this initiative we want to start off with is in primary care organizations, the STOP program. Our addiction colleagues are already dealing with people's alcohol, and now they're adding tobacco into the mix. But for people on the other side in primary care, that, as I said, we really need to look at how do we get an SBIRT guideline into the STOP portal through InnoX. We have this unique opportunity, and we want to figure out a way how to enable practitioners to address risky alcohol consumption in their smokers making a quit attempt. And in doing so, we clearly have to pay attention to all the realities of people's workload, of skill sets, and what's the best way in which this can happen. And so in the next little while, what we're going to talk about, what we want to achieve is looking at how do we streamline the existing primary care pathway to include an SBIRT should the person drink. And the rationale for doing that is if they are drinking and we reduce their drinking, they're much more likely to be successful at quitting smoking. And if they both stop smoking and reduce their drinking, essentially they're going to have better health, especially reduced cancer risk, which is number 2 killer in Canada now. And unfortunately, 1 in 2 of us are going to develop cancer in our lifetime. So what is SBIRT? 3 steps. First step, screening. Second step, brief intervention. And third is referral to treatment if necessary. So you may only need to do 2 steps, or you may need to take the third step. So now we know that there's a wide variety of screening tools for substance use. There's something called the ASSIST, which is used to detect and manage substance use and related problems in primary care and general medical settings. There's something called the CAGE questionnaire, 4 questions, very popular with us physicians because it's 4 questions to ask people, but it's really for detecting people who are at high risk. Like it says, have you ever tried to cut down but find you couldn't? Are you annoyed when people comment on your drinking? Do you feel guilty if people do you feel guilty about your drinking? And do you ever need an eye opener, which is a drink first thing in the morning to get going? And really, this has poor sensitivity for risky drinking. It can detect people who are having problems, and it's much better than doing any blood tests. But it doesn't have that health promotion aspect to it. There's something called the timeline follow back, which used to basically says, let's count the pattern and frequency of your drinking, and basically it's the person recalling, and the recall can go up to 3 months prior, and you can get a good pattern of the quantity and frequency of that person's drinking. And so that's been a validated tool from the early 90s that has been done, and it has various cutoffs. You can do it right down from 7 days all the way to 3 to 6 months. But that's after 6 months, the recall can be pretty bad. And then the most validated tool out there, which is worldwide, developed by the WHO, is this 10-item questionnaire that is called the audit. It's been validated across cultures, different languages, etc., and can widely detect both early signs of this hazardous and harmful drinking, as well as, of course, alcohol dependence as well. So I'm going to just show you an example of what a timeline follow back looks like. And here's what something in print might look like. So on the top end of the slide, it shows you that this is given to the patient. They fill it out. It gives them an image of what a bottle of beer looks like, glass of wine, how much there is in it, and what a standard drink is. So in standard drinks, they can look at back. So say they're seeing you on a Wednesday, then they'll say, okay, on Tuesday, that's yesterday, this is how much I drank, this is how much I had the day before, this is I had on the Sunday, and then they go back to the Saturday prior. Now, I don't know if I can get this pointer to work, but I am going to see if I can. I'm trying to get Tanya to give it to me, but yeah, so she's the one. Am I able to move it, Tanya? Okay, yes. So say I saw them on a Wednesday, I'd get them to tell me what happened on Tuesday, the Monday, the Sunday, the previous Saturday, the previous Friday, the previous Thursday, and the previous Wednesday. And so this can tell you how you can look at how much it is. And this is a validated memory aid for most patients to recall. So that's the timeline follow back. The Audit C screen is another one. There are 3 questions, very validated for primary care, been used extensively, is these 3 questions. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you're drinking? And how often do you have 5 or more drinks on an occasion? And 5 or more drinks is what is classified as a binge. But most people don't know what a binge is, and sometimes people will be out in an evening, they don't realize they've had a binge because they've had 5 drinks or 6 drinks over that evening. They don't consider that as a binge. they just had been drinking, because for them, many people think binging is drinking to get drunk, and that may or may not happen in people who are tolerant. So these 3 questions of the audit C are part of the audit 10, but can be used in primary care very quickly to identify people who are at risk. And the C part of it refers to consumption, because if you look at what you're asking is how often, how many, and when do you, so you're getting a pattern and a frequency out of this consumption pattern. And again, it does not, what you have to remember, this will not pick up people or help you distinguish between those who are at-risk drinking versus those who have an alcohol problem or alcohol dependence. So we have to then take a look at the next part of the audit, which is the full test 10 questions. And this has those first 3 questions there, but the subsequent questions talk about what happens in the previous year, not able to stop drinking once you started, fail to do what you normally expected to do because of drinking, and needed a first drink in the morning, and have you had a feeling of guilt or remorse? So you can see how the CAGE questionnaire is built in there. How often during the last year have you been unable to remember what happened? So this is blackout. This is a neurological problem that happens. Often one of the early indications that people are developing dependence is these blackouts beginning to happen. And again, of course, consequences of drinking like injuries to others. And then again, has anybody ever told you to cut down or to cut down? So this is the full audit screen question. And it can also identify the whole spectrum of non-problematic to fully alcohol dependent problems. So those are some of the tools, and so we've been thinking about how can screening look like in practice. So one of the things that we are introducing into the STOP portal is this timeline follow back that will get the last 7 days, and it'll do it automatically. So when the person is there and you're in front of the person, it'll say, okay, so if today is Wednesday, it'll say yesterday was Tuesday. It'll automatically pick up the dates and ask you how many drinks, and and they may need a little bit of a cheat sheet of the standard drinks on a printout so that they know what a standard drink is, and they can say, oh, well, yesterday I had this many, and it'll calculate that very quickly. And so the calendar will be there programmed to the present day. And basically, if you just add this up, you'll get the number of standard drinks that the person has had in the previous week. And this is what has been used in the CAMH monitor. This is a validated tool in looking at the prevalence of the population of drinking and just getting the 7 days, what happened in the last 7 days. And so, for example, this is how it would be scored. So if somebody had A, B, C, D, and E, it's just a simple addition of adding it all up to know how much they had in their past week. So how do you interpret the timeline? Basically, people are drinking above the Canadian Cancer Society guidelines if for women they're having 7 or more drinks per week, or if they're having 14 or more drinks per week for men. And that's very simple. This is considered at risk. It doesn't mean they're at risk for developing addiction. They're at risk of cancer. Their cancer risk has gone up. So this is a very important thing is when we use language, we need to make sure people are thinking, you don't want to communicate them, well, I think you're developing alcohol dependence. That's not true. What you're saying is the amount of alcohol you're drinking is associated with a higher risk of cancer. So the timeline follow back will fit into this, right? So if the low risk group is in zone 1 is 7-day timeline follow back, they're not drinking, you can say continue, that's great, don't drink and drive, that's wonderful, and you don't need to do anything else for that. On the other hand, if they're drinking above the guidelines, number 2, that's what you can tell. You can 100% tell whether that person who's drinking above the guideline actually doesn't belong in group 3 and the dependent group. And so we have to take that little next step to do the audit C, because that is now getting us closer to, yes, you may be drinking above guidelines, but are you actually having a problem from your drinking? So we're going to exist what is already exists in STOP, a baseline questionnaire, which is now slightly tweaking the questions to meet the wording of the audit C. The wording we had in there was much more for what the population-based approaches were, and they're the same 3 questions. They just had different cutoff categories. So we're just aligning with audit C so that it won't be any different than in any sort of substantive way, except the response categories will be different. So how often do you have a drink containing alcohol? And you can see the response categories go from never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, 4 or more times a week. How many drinks containing alcohol do you have on a typical day when you're drinking? 1 to 2, 3 to 4, 5 or 6, 7 to 9, 10 or more. And how often do you have 5 or more drinks on one occasion? So again, this is not much of a change to the general ways in which we're screening. We're just helping distinguish between at-risk drinking and people in group 3. So the audit C scores by risk level will tell you if they're drinking above the cutoff, 3 plus and 4 plus for male in the score, essentially you know that you need to do the audit 10 because that will tell you whether they're dependent or not. So those two questions help do that because say somebody is drinking above the guidelines but the audit C is negative, then, which is unlikely, but if it is, they are still at low risk for dependence, and you may just need to tell them, look, this is what the guideline says to reduce low. But if people are at that harmful or risky thing level, you will have to do the full screen to see whether you need to refer this person on a treatment or not. So the portal will automatically score the audit C for you. You don't have to do anything. So the audit C scores, if the patient scores below the brief screen cutoffs, it'll skip the remaining questions. It won't even offer you the option of asking the other audit 10 questions. If the person screens above the cutoff, automatically it'll direct the remaining 10 questions. So it's pretty seamless. And people will, and you'll be provided the score for reference as to what your next steps should be. So for example, this is what a screenshot could look like. Scoring above leads to a full audit 10. So it'll show that the audit 10 score is showing up, and then the subsequent questions will come 4, 5, and 6. And so you don't have to worry about this, and the scores are provided to calculate the full audit 10 score. So the cutoffs are given, so for a female is 3 and a male is 4. So how do you interpret these scores? So when you look at low risk, as we said, women less than 4, men less than 5, they have low risk of developing alcohol problems. People who are in this harmful or risky are much more likely to have harms due to the alcohol, and the scores range between 4 to 19 for women and 5 to 19 for men. And for dependent, generally a score of 20 plus, this person is generally probably drinking every day, is having lots of problems in their life, is maybe needing an eye opener, they've been often told to cut down, and this person is often that tip above the iceberg that you can see, and often you don't even need the audit score to know that because just by, there's often, it's quite evident. But it's still important to do so that you can quantify where that person lies. And it also depends because, for the dependent drinker, we often will recommend full abstinence. And for the risky drinker, they may have a trial of reduced drinking first before they try abstinence, and only go for abstinence if they're unable to have a reduced drinking goal successfully. So let's get back to Fred. We have this 55-year-old male. He's married, lives with a partner and teenager. He's employed, has a stressful job, has high blood pressure. He's not obese, smoking daily, he's joined the STOP program, and he discloses in part of this is going to a local bar most nights to de-stress with colleagues. So, and again, I think, I want to go back to what Jackie Allen, and just looking at the notes, said that Jackie Allen, there should be a key point in all levels for those who are women of childbearing years about alcohol and planning pregnancy, or alcohol and pregnancy, no alcohol. And again, yes, that is something that we need to make sure that everybody understands that is for women in childbearing age. And actually, there's a recent paper that's come out that even for men who are contemplating having children, there are some epigenetic effects that might affect their offspring. So even men should actually abstain, and I think this is really a comment that we should be making to all men and women who are considering children, is to not have alcohol because it does create problems. So the STOP baseline questionnaire must be completed with Fred present. So to use this, get the full benefits of intervening with the alcohol at the same time, the way we've designed this is, just so that it's easy to use it, is to do it with Fred present. So what will happen is you'll be given this option of how you'd like to proceed, and you could choose option A to continue with the baseline question online and launch a visit form, or choose the B, go directly to the visit form and have the client complete the baseline question and paper. So we understand not every site is able to do option A, but if you can, this is obviously a better practice because it'll help you do this quicker and faster versus others where they have the client will fill this out as on paper. If you're going to do option A, you're going to be asked this question, is the client with you right now, as you enter the baseline question into the portal, because not everybody uses the portal in the same way. Some people are putting the data in after, some people do it while with the patient present. So if the patient is present, then this is going to work for you. If it's not, you're going to go for option B. Again, this is after, so that's what it looks like. So when we ask Fred, yesterday was Wednesday, Feb 24th. How many drinks did you have yesterday? And he says 5. He's sitting there with probably a little bit of a card showing him what standard drinks are. And then you get through these numbers for the whole week, 5, 4, 3, 5, 6, 7, 6. And the guidelines are less than 14 drinks a week for men, and his timeline fallback score is 39 drinks. So he is having way above what is, even for the low risk guidelines, he's having way above that, but clearly way above the Canadian Cancer Society guidelines. So his brief screen now then continues, so now he gets the audit C because he obviously drinks more than that cutoff. And when you see his audit C, he says he has 4 more times a week where he has alcohol. He's having 5 to 6 drinks when he typically drinks, and he's drinking daily or almost daily. So as we said, if it would skip the audit 10 if he didn't meet cutoff, but if he meets the cutoff, then audit 10 comes on and it'll automatically show you that. And in Fred's case, he's drinking way above the cutoff, and so the following questions pop up automatically, and you can see the rest of the audit 10 shows up, and you can go through those questions with them. And you take a look at his full screen, his audit 10 really starts showing up. He's not able to stop drinking. Once he started weekly, he can find that he's drinking to excess, and he's failed to do what is expected. Almost once a week, he's not able to fulfill his role, and he's needed a first drink at least once a month to get going. How often during the last he felt guilty? He feels guilty almost every day, and he's had about a weekly blackout. He's not injured anybody, and he's been told to quit. And you can see all the points that are beginning to add up for his audit score. So his full audit score now is in 29, and the reminder is risky of alcohol dependence goes up 20 plus points for men and women, and he's way above that problem. So he's at high risk. In fact, he's probably declaring to us that he's actually alcohol dependent. And so what is the best recommendation in this situation? Now, this guy clearly needs that brief intervention to say, look, I'm really concerned about the amount of alcohol you're drinking, and I think you have a significant problem. I would recommend a referral to a specialized treatment center, and I can call Connects Ontario. I know the local addiction treatment center, and I'd like you to refer you there. Or if your center already has an addiction medicine or addiction psychiatrist in there, you could have them see one of your one of the physicians who practices in addictions to initiate treatment as well. Some of you might have a psychologist or an addiction worker in the practice as well, so that you could decide who that referral goes to within the program. So let's take a look at what a brief intervention looks like and what that sounds like. So the big question is to reduce or abstain, and clearly these recommendations have exceptions to them. Absolutely, if you're working with inner city harm reduction program, wet shelter, then these things don't necessarily apply, although these might be goals to get there. So people at low risk, positive reinforcement, congratulate them for their drinking, congratulate them, let them know to keep it at this level, and come back to you if they notice that their alcohol consumption is beginning to rise. Clearly for the harmful, reduced use is a possibility, and clearly for dependent, The standard is to abstain, but for those unwilling or unable to abstain, despite repeated treatments and despite repeated interventions, they probably require a harm reduction paradigm, and there are some centers in Ottawa, Ontario, and Toronto where those things are offered. Okay, I'm just going to take a little bit of a break to see some of the questions and the comments going on here. Yes, you know, some of the people are talking about some of the health effects in university, and yes, and so we really talk about these with young adults as well. So this is applicable to that population as well, and the question is about truth and truth telling. Truth telling is a process, and people will tell the. It's very important to come across with this with a non-judgmental approach. If they feel they're going to get judged, you're going to get an inaccurate reporting. And one of the issues around being truthful is you know, if people know you're not going to judge them, they may not tell you the first time, but you know, they'll come around and tell you. So the worst problem is trying to become the truth police and trying to figure it out, or simply say, I'll double the amount people are telling me. How are you going to engage that person in a conversation of a brief intervention that's going to come up if you know, simply double what they tell you? So it really is a matter of making sure that we have a client-centered approach to this, and when you do that, you get pretty accurate reporting of consumption. And sometimes the inaccurate reporting of consumption is not because of them wanting to lie, but recall bias. And that's why the 7-day seems to be a very good way of looking at the actual amounts. And more importantly, you want to get to is if you're doing the timeline follow back plus the audit, you'll capture harms as well. So so that's it. And again, with the elderly population, again, Marilyn, I think it's about you know, getting corroborative information always helps, as well as with feeling safe. Safety is one of the key issues when we ask these questions, whether it's about tobacco, whether it's about alcohol, and especially when you're asking pregnant women about smoking and drinking. This is one of the things. Yeah, so you know, as these comments are coming on, we're going to take a look at all your, keep your questions coming so that we can make sure that what we're designing can be useful in your setting. And people asking about other STOP programs, yes, definitely we'll come back to that and see how we're doing. We first have to make sure what we're doing is actually feasible and going to work. So let's think about it. And yeah, all right. So I'm going to just come back into it, and we're just going to we'll just come to this back again to some of the questions. All right. So this comes back to that whole approaching conversations about behavior change. There are 3 communication styles. We know we're directing. Now, directing communication styles are when we take charge and we tell people what to do. That's very important in certain circumstances, but that style, if used where, you know, where it has to do with
I can't believe you fell asleep after all that crying. Poor guy.
Yeah, well, the good news is he doesn't have pneumonia. It's just an upper respiratory tract infection or cold. So there's some things you can do to help him get better. You can avoid excessive dust, you can keep him hydrated, avoid over-the-counter cold remedies, keep them away from people who have flu or cold-like symptoms, and avoid smoke. And the last one should be easy because you quit smoking during your pregnancy.
Well, you're right. I did quit smoking when I was pregnant, but actually a couple of weeks ago I went out. My mom was able to take Jake for the night, and my friends, they were having a birthday party, and we had a couple glasses of wine, and felt like old times. So before I knew it, I was out having a cigarette with them. Since then, I've been having a couple cigarettes a day, you know, just at the end of the day after I put Jake to bed. But that sounds like it has nothing to do with what you're talking about, right?
No, wait a minute. That has everything to do with what we're talking about. I can't believe at the end of this appointment you're just slipping in the fact that you've resumed smoking again. That's very, very important information for me to know. And I'd like to spend some time talking about it now.
Well, I had no idea that it was such a big deal. I didn't think it would have anything to do with Jake getting sick or, you know, hurting him.
Come on, Haley. You're here because you thought he had pneumonia. You're telling me that Jake can't breathe, you're concerned about his breathing, and then you just slip in the fact that you're smoking cigarettes and you think there's no relationship? Do I really need to review all the risks of smoking in front of your child or exposing him to secondhand smoke? Not to mention the risks that you're posing to yourself and your own health?
Well, you know, I was doing perfectly well. It was just when I went out with my friends, and, you know, usually I'm fine with the cravings. It's just when I have a glass of wine at the end of the day, and if I have more than 2 or 3, I just get that craving for a cigarette. And if I have cigarettes in the house, it just happens, you know. I'm doing pretty good.
So it sounds like if you have alcohol, then smoking is very difficult to avoid. And you know what you need to do. You need to go home, and as your son's doctor, I need to tell you, you need to go home and throw out those cigarettes. You need to quit.
Okay, well, yeah, I guess I can throw out the cigarettes, and tomorrow night when I have my glass of wine, I'll just try to avoid that craving.
And let's talk some more about wine. You keep throwing wine into the conversation. It sounds like it's become a significant part of your daily routine. How much are you drinking?
Only a couple drinks a night. You know, it's pretty rare if I have anything more than that. It's just my way of relaxing at the end of the day. It's been so stressful since Jake came along. It's just how I fall asleep at the end of the night.
Well, no one said motherhood was going to be easy, Haley. So let's talk about these drinks. Are we talking about the low-risk drinking guidelines, 1 to 2 standard drinks a night, or are we talking about a mug of margaritas?
Well,
what are you drinking? What's the quantity that you're drinking?
I guess I have about a half a glass a night, and maybe 2. Very rarely I'll have more than that. You know, it just helps me kind of relax.
There's other ways to relax. There's yoga, there's deep breathing. You need to stop raising the roof and raise your kid. This is not okay. You're not just worrying about Haley anymore. It's Haley and Jake. You're a mom now.
Oh, I didn't know it was such a big deal. I never thought there would be any impacts on Jake because of it.
I'm trying not to be hard on you, Haley, but I've got to tell you as a physician, it's a very big deal. Your drinking and your tobacco use are red flags for me, and they need to stop immediately. So we've already talked about your plan for smoking. You're going home, you're throwing out your cigarettes, you're putting on the patches. What's the plan for the alcohol?
I guess I'll do the same thing. I'll go home and throw out the bottles of wine and stop having a glass at the end of the day.
Sounds good. And if you need to relax, go for a walk, join a mom's group, read a book. How about you come back in a week when we have Jake's 6-month checkup, and you can let me know how that quit plan's going.
Okay, I'll try my best.
Thanks.
Yeah. Yeah. He's so good in this video. Okay, so sorry about that for those who couldn't hear the sound, but we've given you some links as to where you could find it online. So what we want you to do is type your responses in the chat box. What do you think are some common patient reactions to being spoken to in this way, in a very directive way? Yeah, I can hear defensive, people shut down. Defensive is coming up a lot. Absolutely, it's the commonest way, you know, because they're feeling ashamed, they may lose trust with us, they get frustrated. Client feels threatened. I would not go back and I would find a new doctor. You know, again, people will have different responses to this. It will generate a lot of negative emotions, and the behavior that comes from that negative emotion generated by the practitioner can lead to either withdrawal, silence, or actually completely leaving that practice or going on. And sometimes people have that ability or don't have it, but in essence, this is not often very helpful to then go on and actually change. And then much more likely to provide information that is dishonest. So exactly, so some of these things came up. So thank you so much. And Haley really tried to stay surprisingly open and responsive, exactly. And I think that's one of the things is that sometimes patients, stay much calmer than we are sometimes. But really what they're actually going on inside may be very different. So, people have different communication styles, and Haley has a communication style actually, which is pretty good here, given what was going on. And so, will this work? People can always have an anecdote where this might work. It could also be highly possible that she has a long-standing relationship with this physician or this provider, and we didn't, and this may be the way they talk. But in general, this is what would happen if people spoke to us in this way. So, on the other hand, when we are thinking about a much more guiding communication strategy, as you know, we're really looking at respecting the person's autonomy. People have a right in a democratic society to exercise both good and bad, do good and do bad. There are consequences, of course, for that, but, we have to respect their autonomy to choose. That's a fundamental aspect of living in a free Western society. We respect people's various goals and values. We also understand in guiding communication that the readiness to change is a state, and it can fluctuate. It's not that somebody is motivated or not motivated. It's a time-based issue that happens. We also have to become comfortable with ambivalence, that people are not always ready to make a change, that they go back and forth. We also respect that the patient at one level is an expert on their own lives. We may be content experts on what is to be done, but the patient is the expert on how they live their lives. And also in a guided communication, we definitely have empathy and demonstrate empathy, are non-judgmental in our approach to people, and we are respectful in our communication. We don't have to agree with what somebody is doing, or we don't have to condone it, but what we do have to do is have empathy for that person's point of view, be non-judgmental, and respect their autonomy in choosing this. So we're going to show you an SBIRT that comes from the U.S., which, Tanya, I don't know if you can rough, and
Steve is a 30-year-old male presenting with the chief complaints of insomnia and feeling anxious. Steve's audit score places him in Zone 2, the risky category of use.
Which makes me cringe.
Steve,
And,
before we're done with our visit today, I was wondering if you'd be willing to take a few minutes to talk about your drinking.
There where that experience has happened.
Well, you filled out this survey for us today, which is
for
great.
whatever,
Thank you very much. I just want to review a couple things
reason,
on here.
that actually
I
got the
noticed that
person
you
in to come and
said that
see
you
you.
drink
So
2
if
to
that
3 times a
works,
week.
how can we
Drink
leverage
3 or 4
that?
drinks at a
It's
time
not
when
a
you do
recommended
drink,
way
and
of going, but
weekly
how can you leverage the
have
fact
more
that
drinks
the
than that.
patient
So
has
6 or more drinks, it says
experienced
on
that,
here.
and how
Does
can
that
you use
sound
that
realistic?
to help them
on the weekends.
find their own motivation?
Okay, I just want to let you know I'm a little bit concerned about your level of drinking. We know that excessive drinking can make problems worse or can actually cause health problems at times. And I was just wondering if you thought about the connection between your drinking and things like the anxiety and the insomnia that you came in with today.
No, I guess I haven't really thought much of it.
So I'm trying to
I don't really think I drink that much in the first place, so I have a hard time believing that it's causing my anxiety. In fact, on the nights when I don't drink, I have a harder time going to sleep.
Well, you're not alone. A lot of people think that drinking helps them sleep better. And in reality, drinking might make you fall asleep faster, but it has what's called this rebound effect. And this rebound effect means that you might wake up in the middle of the night or early in the morning and have a hard time falling back asleep.
Well, I guess I do have about 2 a.m. I tend to wake up on the nights I drink too much.
Well, I just wanted to show you this little chart here. For your age as a male, you're drinking more than those at a low risk level. The low risk level for men under 65 is no more than 14 drinks a week and no more than 4 a day. And in this case, a drink is considered 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of distilled spirits. And you're right, you're not drinking as much as some people out there. The way you answered our questions here, you're actually falling in the high risk category, the risky or hazardous category, category 2.
Geez, no, didn't think I was that bad.
That's why it's helpful to look at this and give some perspective. On a scale of 1 to 10, what is your readiness to change? 1 being, I don't want to change at all, and 10 is, I really want to change.
I don't know. I mean, this is all news to me. I don't want to do anything to put myself at risk, and I've always thought of myself as a pretty healthy guy. I guess I'd put myself right in the middle at a 5.
Well, that's great. That's halfway there. What kept you from just giving it a 1 or a 2, something lower?
Well, you know I'm training for the marathon, and that's why I'm coming in, is because I need to be able to get my sleep back on track. But I also don't think of myself as a hazardous drinker, and I'm certainly not an alcoholic, so that's why the middle ground, 5.
Okay, well, that's a good place to start. So I heard you say your health is important, and you're getting ready to run a marathon, so you want to be able to do what you can to make that successful, and you also were a little bit surprised that you fell into this risky or hazardous category.
Yes.
Okay, so based on all that information, what are you willing to think about doing to change right now?
Well, I think the natural thing would be to cut back a little on my drinking.
Mm-hmm. So what would that look like for you?
Yeah, I guess drink no more than maybe 3 or 4 times a week, and on the weekends, which is when I would drink the most, cut back to no more than 5 or 6 beers.
Okay. Okay. Well, sometimes when people are ready to make changes like this, it helps if they write down their goals, gives them a chance to see them in black and white. If you were to look at this little form here and figure out where you want to go with your drinking, what would you put down as your goal?
Doing the math, I guess, no more than 18 drinks a week.
Okay. So that's an improvement. So you're headed in the right direction. I do want to let you know that with 18 drinks a week, you're still falling above this low-level risk category. And it would be my recommendation that at some point you would fall below into this 14 or less a week. But it's an improvement, and it's a great place to start, and I really commend you for your willingness to take a look at this and try to make some improvements.
Thanks.
So I'm hoping that in your appointment next month we can touch base on this and see how it's going.
Sure.
Okay, good.
All right, so you can see that if you saw that video, it's 3 to 5 minutes, right? It's not a long video. I mean, it shows you that 3 to 5 minutes can have a significant impact. And what is really important is this personal feedback. When we're looking at what are active ingredients of our interventions, when we can personalize it to people, and this is when they can say, here's how other people drink, here's how I drink, oh my God. You know, and I can actually change this. And the interesting thing is that this, in SBIRT, it can be performed by any trained clinic employee. In fact, the Oregon SBIRT program has what the front desk staff do and what the other clinician does, and they have, you know, how they make it all happen. And much like how we've done it in STOP, in fact, actually, in that the physicians have a very limited role in the operationalization of SBIRTs. Other than making sure that when they identify a patient, they send them on to the right person in practice. And again, motivation interviewing, again, which you have through your TEACH training and through STOP training and other training, we know that it improves health outcomes, including diet and exercise. And so that's one of the reasons why TEACH is based on motivation interviewing, because it has applications across multiple health risk behaviors: alcohol, tobacco, sleep, diet, stress management, physical activity. So, so it's using those same skills in doing that. And so what was, for those of you who are novice to it, that video showed you all the ways in which to do it. For those of you who are more expert at it, can clearly use and adapt your motivation interviewing skills to provide that brief intervention, which is essentially engaging the patient, raising the subject, focusing them on a particular behavior, and evoking change talk and getting a commitment to a plan of how to change that behavior and follow up. So what are the evidence-based brief intervention steps? Clearly, part of this, you recognize this from tobacco 5As, advise the patient of at-risk status that, based on the amount of alcohol you're drinking, this is where you're falling, and you can show them the card compared to others. This is what you're doing. A clear advice, which is non-judgmental. Based on what you drink, if you'd like to reduce your risk, my strong advice is for you to reach this goal or stop altogether. Step 3, hey, we've been there. Assess patient's readiness to change. How ready are you to stop? And then either step 4, if they're ready, and negotiate a goal or develop a plan, or as we said, if they're not, restate the concern and engage in more motivational interviewing around getting them ready and keeping the door open for them to talk about this at a future date. So the step 1 of the brief intervention, where advise patients of an at-risk status, is response to the screen questions act as conversation starters. Obviously, always ask permission to discuss alcohol use. Would it be okay if we spend a little minute about, I know you're here for smoking cessation, but based on your alcohol, what you've responded, could you tell me a little bit more? Here's what I've seen. You may not even need to have that open-ended question. You could say, here's what I have. How do you make sense of this? How do you think this is related to your smoking? So you can engage it and integrate it into your behavior change plan as they're coming along. Clearly, you could explain the low-risk drinking guideline, say, look, any amount of alcohol, whether you're trying to quit smoking, will reduce your chances of being successful. In general, alcohol and tobacco cause harm to you, especially the cancer risk, and also talk about your current state and what is the relationship between that current alcohol and any health behavior. So if they have diabetes, hypertension, etc., those are all things that you can bring in, because as we know, most of our people who are using tobacco are coming in to stop have a chronic condition or have another mental health or addiction diagnosis. So the chances are these people are sick and have other conditions for which alcohol is also going to affect that. And clearly, if they have depression, drinking alcohol, or they have anxiety, drinking alcohol is going to worsen those conditions, just like tobacco use does. And so clearly, recommending reduction or abstention is an important part of a brief intervention. We have this importance, confidence, or readiness ruler. So these are the same things that we do for tobacco. You could similarly do that for alcohol. And again, asking about the pros and cons of use. So what is good about drinking? What does it allow you to do? What's the downside? How does that? And clearly, in that conversation, tying it back into that quit attempt and how is that affecting their smoking. If the patient is ready to change, what would you like change to look like? Restate the recommendation and provide resources or referrals to treatment and schedule a follow-up. So this is no different than what you're doing for tobacco. And remember, you don't need to do everything all in one visit with respect to the brief intervention. It can be, if they're part of a roster patient population in yours, you can bring them back and do other parts at different times. If patients are ready to change, we know exactly what this is about. We've done this with tobacco. It's no different. Encourage reflection, reaffirm willingness to help when the patient is ready, restate our concern. I know, Mr. Jones, you may not be ready to stop drinking right now, but I am very concerned about how alcohol is affecting your ability to quit smoking, as well as X, Y, and Z. And say, as a heads up, at your next follow-up appointment, I'm going to find out how you're doing. And if, with your permission, I'd even like to talk about how your alcohol consumption is, whether it stayed the same, gone up, or gone down. So again, a brief intervention in practice with this is, we'll take a look at Maria in this situation now, because, as a 23-year-old female who's really, when you look at what she's going to be drinking, here's what you're going to get. She's had one day in the week where she's had 5 drinks, but the rest she's having 2. She's had a couple of days where she hasn't had any, and she's had 1. So when you do that calculation, she's above the cancer guidelines of 7 drinks a week from the Canadian guidelines for low-risk drinking, she seems to be okay. But from a cancer guideline, she's having higher consumption than recommended. So again, she'll automatically get the audit C, and you'll see that she has 4 or more times a week she has alcohol. She usually has 1 to 2 drinks, and she's had monthly she binges at least once. So the portal will automatically calculate her audit C score. She falls above the cutoff, and so here's the question to you. What would you do? Nothing. We have all the necessary information, and here's the poll. You can decide whether or not to complete the full audit, or the portal will automatically direct to the full audit. So please vote. Pretty good. We're getting, while the results are coming in, I'm going to end the poll and just simply say yes. For those of you who are doing it with the person there and is happening, it'll automatically calculate it for you. If you're doing it by paper, obviously then it's your decision whether you're going to do the next one or not. But otherwise, it'll automatically offer it to you to do. Okay. What is the next step? So now we're going on to the next slide. And it'll automatically direct it, but remember the caveat is only if you're filling it out with Maria present. Okay, and you're going to get the audit C score for reference. So when you look at our audit 10, here you can see the audit C score is showing you it's at a 6, and she's above the cutoff of 3, and then it asks these other following up questions for you to ask. And again, when you look at her full audit score, she only scores 6, and a total of 10 points from the full audit. And she's not at the risk of alcohol dependence, so it does not reflect a risk of alcohol dependence. Clearly, of course, if she's of childbearing age and is planning to get pregnant, then obviously you're going to advise her not to drink at all. But if you are Maria's practitioner, what would your next steps be? Skip a brief intervention, complete a brief intervention, 2 choices. Okay, so yeah, so we'll just close we're pretty much there. Yeah, I mean, this is the issue, right? It doesn't look like she's high functioning. This is that below the iceberg. These are the people who you would think, yeah, this person doesn't look like, they're not falling over drunk, they're not at this excess amount. In fact, she may be drinking just like I drink. And so why would I do a brief intervention? But actually, even though she scored below the 10, from the timeline follow back and the audit C cutoffs, she is drinking an amount that is associated with a higher risk of cancer. And it's a brief intervention. A brief intervention isn't about just saying, you know what, I'm sharing information with you. And again, how do you stay safe through this? And clearly, of course, if she's a woman of childbearing age and a man of childbearing age, or whatever, able to, it would be suggested, or planning on having a child, not to drink. So again, it'll be focused on reduction of alcohol. This person is not somebody who would be referred to an addiction treatment program because they're drinking to excess, but really the first intervention would be to try a reduction in alcohol consumption to below guidelines. Now, when do we do the third one, which is referral to treatment? Clearly, what does treatment mean? And in this situation, we're going to say there are 2 options. One is a reduction in alcohol intake, and what that means is really they need educational resources. often self-help workbooks or fact sheets, agreement form, maybe tracking sheets. Those are all things that can be done for people who are not drinking above guidelines, and just educating them about this. Often they'll say, I never knew there was a risk of cancer, and I don't want to get cancer, so I'm going to do everything I can not to do that, and so I'm going to reduce my alcohol consumption to the guidelines or less than the guidelines. Or there may be people who want to abstain from alcohol. You can give them the educational resources and referral to a specialized treatment. And the list of options for specialized treatment in the local area, it's always a good idea to have that, or referral to a counselor, addiction therapist, or addiction psychiatrist, or addiction physician in your practice if you have that resource available. So what are workbooks? Some of the resources are workbooks. We have packages which include tracking sheets, agreement forms, and fact sheets. This is something that comes out of Capitol Health Addiction Services. It asks them to reflect on what has worked, what hasn't worked, for example. Other fact sheets about alcohol and cancer risk, and this is something that we will share with you from CAM8, so you have this evidence-based information sheet. A contract, if you want to set a contract, there are these agreement forms. Some people like to use them, some don't. But these are evidence-based resources that exist from the College of Family Physicians and CCSA that are out there. The tracker, this comes from the National Institute of Alcohol and Alcoholism, the U.S. Here's how you can have a 4-week tracker, and this can be, it's a card that can be made out for the patient. And so these are some of the resources out there. Then, of course, we have the CAM8 Saying When app. It's free and great for those who want to track when. And I've got to check with whether the Saying When app is now free or whether there's a cost on the App Store for download. I'm not 100% sure. I thought there's a small cost, but maybe it's gone. Oh, it's free now. So thanks, Jackie, for practicing. And maybe you want to put a link to the Saying When app if somebody else wants to put that. That's another app that you can refer people to. So what does it look like in practice? Clearly reduction or abstinence, and there's a package. Only one alcohol resource package can be provided to each patient whether you're choosing reduction or abstinence, and you can select it based on the score or the screening tools. On that resource page, on the portal, there'll be other resources as well. These can be stress, nutrition, sleep, physical activity, and how do you share it? If the person is with you at the time, you're going to be asked, how would you like to share this? You can email it, print it, or hand out pre-printed resources that you might have. These resources will be housed on the CAM8 website. And as we said, the options could be email. It'll auto-populate with the patient's email address that they provided at the time of registration. And the email that they get will contain the URLs to the selected resources on the CAM8 website. The print portal will generate a PDF of the selected resources to print if you like in your office and hand it out. And you can have them pre-printed and use them as with the patient when they're there with you and give it to them. So we're creating a range of resources that you can adapt to your setting depending on what is feasible with your setting or what the patient wants. So you have many options. So having thought about that, which method of providing resources will you likely use most often? So we can see that most people on this call would like pre-printed. Some will print it themselves and some will email. Very few will email. So that's good to know. And clearly people will have options and people might change their minds or have that. But you'll have various options of how you want to do this. In terms of meeting AODO standards, generally our TEACH project and all our projects are moving towards making sure we meet these standards, as we all must. And right now there is no Android version. I think right now there is no Android of the app. It's only a Apple-based version. And so it's not available on Android. And okay, so moving right along, we will take that feedback about the app. I will be talking to our colleagues in the education department about what plans there are for getting this much more available for Android products. Okay, so here's what we look for, figuring out what is the best intervention strategy. As you can tell, we are trying to be participatory and get your input into it, and we assume that most people will like the email, but as you can tell by the poll, most people said we want pre-printed and we're going to give it out pre-printed. So searching for the best intervention. The screening, we have access, all sites are going to have access to the screening questions. What we really want to explore is, in one approach, practitioners can use the screening results to select appropriate brief intervention for applicable patients. And in a second one, should the portal prompt you to provide the brief intervention to applicable patients? In theory, they both are good, but we have no idea which one is more realistic and usable in the real world where you work, especially in primary care settings, because you're an expert as to what's going to happen there. And what may work in one practice, as we figured out with STOP, may not work in another. And one of the beauties of STOP is the fact that we have 80% of family health teams and close to 80% of CHCs and 75% of nurse practitioner-led clinics coming on, tells us that there's adaptability in this, that people can adapt and use this as they see fit. And we want to do the same thing when we're trying to do this alcohol. So there are two sort of dominant ideas. One is just the screening results are there. You do decide what to do with it if you want to do anything about it. And the other one is there's a little bit of a nudge in the pathway so that it can help in the busyness of the clinic, or if there's a different staff member coming on, this might just all be kind of automated. So, and then of course, all sites will have access to the treatment option. So really we want to figure out which one is better and which one isn't. Yeah, and again, the tools about literacy and all that, we will be paying attention to, are these tools appropriate or not? And again, we will pre-test them to make sure that they meet some of those requirements. We've had focus groups with some practitioners about what they want, and so we will certainly engage this community of practitioners to tell us what they think about some of the resources that are coming out as well. So, in summary, these are the references, but I'd like to summarize. Alcohol and tobacco together have a multiplicative effect on cancer risk, especially the aerodigestive cancers. That's one. Two, in our STOP participants, their drinking is above guidelines, and the number of STOP participants who drink above guidelines as a percentage is greater than that you would expect in the general population. Roughly, we have about 8,000 people in the whole cohort in primary care who are drinking above guidelines, who could get a brief intervention very simply within 3 to 5 extra minutes, that in one out of every 3 people who we make that intervention will reduce their drinking. In doing that, it's asking for an addition of just a timeline follow back. The audit C questions are already there. If necessary, the audit 10 will pop up, and you can make a decision whether they need no intervention, a brief intervention, or a referral to treatment for alcohol problems, and you'll have access to the resources necessary to do that. So roughly, but what we don't know is whether we should be nudging people or not and just leaving it, is that's the best way to get the ultimate adoption and best quit rate. So we'll test this out with you and see which ones are going to work, and does that have any difference on the quit rate that we are seeing in smoking cessation. So are the practices that actually have the nudge, do they do better, and do they actually have a higher quit rate compared to those who are just simply given the information? So roughly that's what we are trying to answer, because just because we can design the technology doesn't mean that it's the right thing to do. So we first want to make sure, as we are developing this, we want to make sure that it actually works within your setting. All right, so we're going to open up for some questions, and I guess there were some discussions going about literacy levels. We said we'll talk about that. Okay, so Shell asked this question about, very good question about the needing to revisit it at the alcohol question on the portal. I don't always have time at the initial visit. And we'd like to hear more about that and see how we could, so what functionality would be needed. And some people would like the prompt and override it based on your assessment. Yeah, so having control over prompts are important. And again, that's one of the things we've noticed is that everything should have the ability to override. Everything that is automated needs an override because as a human, you're much more able to see the context than anybody else. So it is important. Okay, so open it up for questions. And I think because we have about 119 participants online, it'll probably be best to do it by the chat function. So I think from a design perspective, the North York Family Health team is suggesting ability to defer review of the alcohol resources until a subsequent visit would be great. Okay, we'll think about how that might be designed. And the follow-up forms, would they ask alcohol questions to assess if changes? Yep, absolutely. There needs to be something so that you've done something, and when you re-ask the question, it's important to know what, did it actually change, or did it actually go up, or is it the same? So the specific risks of alcohol consumption, the dose-response relationships are ranges. So we are trying to look at or develop what are some of the dose-response relationships of alcohol consumption and patterns of alcohol that lead to problems. And some of it is putting it together in a way that makes sense. So we don't want to overly scare people, but we also don't want to underrepresent the risk. Yeah, so there's a reason. So this question is, why should we tell men to abstain from alcohol? So just like tobacco smoke, alcohol is a carcinogen in and of itself, and alcohol, for most people who don't know, also has formaldehyde, acetaldehyde, and other carcinogens, the ones that we all worried about with electronic cigarettes. They also have these issues. So you could let them know that there are carcinogens in this, and these carcinogens actually do go and attach themselves to sperm, and these are called some of the epigenetic changes, which means things that go and attach to the genes that moderate how those genes function. So our genes, essentially, our chromosomes are sort of wrap up the genes, and these things that wrap up the genes unwrap to expose the genes. And toxins in our environment can alter the way those genes are unfolded. So by damaging those control mechanisms. So alcohol does that. And part of it is it can become, in some of the emerging evidences, it can be inherited, which means it can be those defects to those genes can be transmitted to the next generation, and then that generation can transmit it to the following generation. So this is very exciting recent sort of data showing that alcohol can, and the effects of alcohol can be transmitted not just through women who drink, but through men as well. And clearly alcohol affects fertility, and smoking affects fertility, and also affects the ability to conceive. So we will try to put those resources together and send you that paper as well. It's a bit It's a new paper, it's a new review, but certainly something we could share. Are we going to receive reports about this part of the assessment on your portal? Vera, we would need more details about what would be helpful to you. That would be really great if you can send us an email of what you'd be looking for, and then we can see how we might be able to design that into the portal to give you feedback. We are going to get a letter to all of them, to all the sites who are, about what some of the changes that are coming, and the rationale for why that change is happening. And of course, if there are any questions that the EDs or the MDs have about it or any concerns, then clearly we want to hear about them. So we will be doing a communication and follow-up of this before. This is not ready to go live yet. We're hoping sometime in the next month or so. But before we do anything like that, we are going to have to make sure there's clear communications about what is happening and what the impact is. And there's always ability of clients to decline from any part of this. I mean, in essence, if people can decline from anything, I mean, roughly, but what I would suggest is that when we're trying to provide comprehensive care, we have to understand why we're doing that, right? And sometimes explain to them why some of these questions are collected. For example, the income question is an important one. Because what we notice if the ministry decided to put NRT on ODB, the majority of people who are participating in STOP would not have been able to access NRT. This is the working poor. And so if we are able to get at least an indication of this, this is extremely important in helping policy about how tobacco-free focuses on our working poor, because they don't have insurance, they don't have coverage through health insurance, and then they don't have access to evidence-based quit aid. And similarly for alcohol, as you know, as the government is moving to make alcohol much more freely available, we predict problem drinking will go up. Alcohol dependence may not go up, but problem drinking consumption will go up, much more likely to go up, and we're going to have many more people drinking much more frequently and coming to harm. And we predict that the harm will be faced much like tobacco with people who have the least amount of income, least amount of education. And so, I understand people always have a right to refuse, but if you as a practitioner can help people understand the rationale for this and how it ties into what they're smoking and quitting smoking and how this helps them and others, it might be one way to get them to understand that this information not just being collected for the sake of collecting information for an academic paper, but it's really helping move the system so that we can focus much more on these preventive things like alcohol, like tobacco, and prevent chronic disease. So, Crystal, let us know, in terms of the sheet of what we want to share with MDs and other team members, please let us know what would be helpful, length, etc. We are happy to create all sorts of resources to make sure that this is helpful for you as an implementer. And again, in providing people the information, you're right, dosing the information is important, and how to make sure. So clearly we want you to have that flexibility. You know the patient. Some people want it all at once. Some people want it in chunks, and that's where that email option provides a little bit of a break because they can access it at a later date. So we're creating all that flexibility so that you as practitioners can decide within that frame what's the best way to give the information. Dennis wanted to know, is any type of alcohol less harmful, such as wine versus hard liquor? Not really. I mean, alcohol is alcohol, and that's why we've gone to that standard drinks of the, so if you're having 13.6 grams of alcohol through wine or through hard liquor, it's a problem. So, lots of people believe that wine and beer are less harmful than hard liquor. Clearly, if you have the same volume of hard liquor as you had of wine, hard liquor is worse because it's more concentrated. But so people need to understand that concept of standard drinks. Jesse asked, how long males abstain before impregnating someone? This is a great question. We know that the men's sperm is constantly being produced, and to create a full turnover of sperm, it's about 3 to 6 months. But 3 months is sort of a minimum. And that's what we know, and roughly that's in terms of smoke. And it's similarly with smoking. After quitting smoking, it takes about 3 months before the sperm will return back to normal. And in some of our pregnancy programs, we've shared a slide of you showing you pictures of what tobacco smoke does to sperm. And we'll try to find what alcohol does as well and see if we can find something like that, like a visual. When will these alcohol questions changes come into play? When will they be on the portal? It's still in a design phase, so we are not sure, but we are hoping for about 30 to 60 days from now, but stay tuned. We'll always be having communication. Nothing's going to come as a surprise. You're gonna know when it's changing. Okay, so Vera's responded what she wants, and so we will take that into consideration. Yep, and Marilyn, I understand that patients on ODB and resident and long-term care do not have access funds for NRT. This is a problem. The long-term care home facilities should be providing this, and we are constantly taking this back to our ministry folks to see how we could create some resources for that group. Okay. Where do we go next? Though, as we also connect on MJ and opioids, we're going to move to legalization of Mary Jane. I know we didn't want to, I guess there's so many things that we could go down, and I think, Robin, thanks for highlighting that. We also collect, this Mary Jane information. We have had topics around that, and we're going to have to just figure out how we're going to bring it all together. And I think generally when people are using multiple substances, the possibilities that these people are going to need specialized treatment, it goes up. And so I think those collaborations with our colleagues in the addiction agencies is going to show up as being critical, because they may be able to do an all of substance approach for that person who's using multiple substances. And in terms of the geriatric specific, we will take a look at the age cutoff for audit and see what that is. I know you've talked about the MAST modification for geriatric, and we'll see what is feasible in this older adult screening as well. And we'll take a look at that older adults of 55 or 50, and we'll take a look at which one and at what age range of the cutoff. So if I'm not mistaken with the audit, we have do we know the age yet? We'll take a look. I can't recall off, but we will take a look at that. And if other people have ideas about it, please let us know. All right. Other questions or comments or concerns? In our estimate, we think that in a smoker who is trying to quit smoking, we're trying not to add anything that's going to take more than 5 minutes. So that's the goal, is to keep this, because it's an important outcome. It's hopefully less than 10% of your total time that you're spending trying to help the person quit smoking. But especially since you are spending that time helping that person quit smoking, all of us want to make it the most successful. And so this is one. I know we know there's marijuana and opioids are also factors that interfere. Depression interferes. We are hoping to address these as well. And again, primary providers on board for about the brief screening. There are tons of videos on SBIRT, but I think let us know, Vera, what you're thinking about in terms of just getting them on just the audit C and the timeline follow back. Is that what you're asking us to get them to look at, or getting them on board is around the risks of drinking, smoking together? Is that, what is it? What elements would be helpful? We've created a whole, if you go to the College of Family Physicians website, Prevention in Hand, there's a whole series of videos there for family doctors, actually, endorsed by the College of Family Physicians, on how to do brief interventions for alcohol, tobacco, and a whole bunch of health behaviors. And that's it. So there's a bunch of resources there. but let us know what we are thinking. And remember, behavior change is a process. Don't let the technology and do that be a problem. Yes, we have actually a problem-based module called CAMAC at McMaster, which we helped develop with McMaster. And Claudia, I think you're talking about that learning tool. So if there's additional training or learning that people want about this, we can certainly advise you about all the additional training around alcohol and alcohol interventions that there is. What I didn't cover today is actually the pharmacotherapy of prescription medications for helping people who are alcohol dependent. For that population, they need withdrawal management, which is often in a non-medical withdrawal center. If they have history of seizures or medically unstable or heavily dependent, they can get usually benzodiazepine short course, either as a loading dose in a intensive care place, an emergency room or a family practice or an addiction center that can do that. That's sort of the evidence base. Or they can get short course tapering doses of alcohol under supervision, tapering doses of benzodiazepines under supervision. But what is then known after that to help them stay stopped, there are 3 medications that are available. One is, the oldest one is Antabuse, but that's only available through compounding pharmacies, not covered by ODB. The medication called naltrexone. There's another one called acamprosate. Both of them are used in the treatment of alcohol. They are on ODB, Exceptional Access Program. They can be got through the STAT program. We are currently working on getting it off that so that people can put it on a limited use or access it. And 1 in 7 people who are given that medication when they're drinking in heavily dependent ways can actually respond. And in fact, if you look at smoker drinkers, combination of nicotine replacement and naltrexone will help not only their drinking, smoking, but also in women reduces weight gain. So the pharmacotherapy, we didn't spend too much time on this, but if for those of you who are prescribers on this, be aware that there are some good medications, or if there are prescribers in your practice who want to have a webinar or talk about medications for alcohol and tobacco together, we are happy to put something together that talks about going beyond just nicotine replacement, but using varenicline and bupropion and all those kinds of things in combination with alcohol reduction medication. There are other off-label medications that are there, one called topiramate, and baclofen is the other one that we use. Both of those are covered under ODB, and we use them for alcohol dependent, people who are severely dependent. Of course, those individuals also need referrals to addiction treatment facilities. Some of them may want to attend mutual aid groups like Alcoholics Anonymous. Absolutely, they need the comprehensive care around their addiction treatment. So that's very quickly covering what we would do. We didn't cover that today, but if people are interested, we could certainly do a separate seminar on that. And we'd get a bit of a needs assessment, see how many people would be willing to show up for something like that, and maybe do it as one of our lunch and learns. You'd like more resources for mental health practitioners associated with mental health physician teams. Rupashri, please tell us what exactly you'd be looking for. We have a whole bunch of resources. If you actually go to porticonetwork.ca, at CAMH, and that has a whole host of resources of mental health and addiction resources for both primary care and mental health practitioners. So, please take a look at that. People are talking, Miriam has a question, relapse in patients with mania. I'm not sure what that means, but if you want to just complete that thought about what the question is, do people with mania relapse, or should, there's a big association between drinking and mania and depression and mania and smoking as well. And Kathy, you're more than welcome. Thank you to everybody else who's actually, seeing the importance of this and helping patient populations all over Ontario to actually stop smoking. And it wouldn't be possible without you. So thank you. The use of varenicline in geriatrics. again, the question about agitation and suicidality. One of the things with agitation is when people go into withdrawal, they will get agitated. That is a symptom of nicotine withdrawal. And varenicline can actually do that. So with the geriatric population, we will actually use lower doses. And the risk of suicidality is actually kind of overblown. I think we need to do a risk assessment with the patients, make sure that they're fine. And as long as we are monitoring them, I think that risk of suicidality it's not showing up in some of the subsequent studies, and you know, the risk is low. What I'm more concerned about actually is whether they are having effects on this agitation because they're going into withdrawal as soon as, so they really need to, and my opinion is they need to start that first dose at least having not smoked for at least 8 to 12 hours, and therefore the medication can work is the way it's supposed to, and that and over time that the agitation actually settles down. So so that's how I would look at it. All right. So people are saying they want some pharmacotherapy seminars. We can do that. So Miriam says going back to patterns. So patients, relapsing patients with mania going back to patterns. Yes. That's a bit more complicated. People with bipolar disorder can actually, as they are fluctuating their mood, they use alcohol to modulate their mood, either to bring themselves down or sometimes when they're depressed to bring themselves up. And so I would suggest that requires some a specialized assessment to see where their drinking is going. Often what we want people with bipolar disorder who have substances is to be really abstinent, because we know when they get abstinence from all drugs or abuse, their mental state actually stabilizes. So if they're drinking, often we will use things like topiramate or Topamax, because that is both a mood stabilizer as well as can help their bipolar disorder. All right. I think we are almost coming to the end of the session, and okay, and Shauna, I think you're right. Relapse rate, both substances are addressed. So essentially, when people quit both, their risk of relapse goes down substantially for both. So so clearly that we covered that in the first webinar, and that. So, and I think Robin Brown said at least one study says that the risk of suicidality with varenicline was more correlated to sleep disturbances from the drug than underlying risk of depression and previous attempts. Not sure how good that study was, but found it interesting. Yeah, I think these are really interesting questions. I think more and more data is shown. I mean, I think the best thing is that there have been over now 8 million exposures to varenicline, and the suicides are really, really, really low. So it's maybe the risk is less than probably, we used to say less than 1 in 15 to 16,000. It's probably even less than that. Remember, the risk of a seizure from any antidepressant is usually 1 in 1,000. So we've got to put this into perspective as well, because smoking is 1 in 2 risk of death. So we've got to think about this all. Anyway, so I want to thank everybody for their participation. I want to thank my team for putting this together. I want to thank Aliyah, who's here behind me sitting quietly, who's helped put the slides together, and Nadia Minion, who also works with me, and for putting this together. So we always look forward to your feedback about today's session. I'm overwhelmed by the number of people who've taken time out of their schedule to be with us and spend the Thursday morning with us.